Hello everybody, this is Chehing calling out to all of you from CHI. COVID-19 has disrupted our lives in many ways, but certainly not our determination to innovate for a better health system. As CHI moves into its next chapter of growth, we remain even more committed to building thought leadership, workforce transformation, and strategic programs that deliver value to all our stakeholders. As such, I'm pleased to announce to everyone that CHI will continue to hold its annual co-learning flagship event, CHI Innovate for 2022. The theme for this year is the road from innovation to impact, and we would love to have a conversation with all of you to talk about how we can better deliver value and impact to the rest of our health system. And here to share more about the program with you is Hon Tim.
Thank you, Chehing. Hi everyone, I'm Hon Tim and I bring greetings from the scientific program team. We've decided that CHI Innovate 2022 will take a whole year to walk that road from innovation to impact. Starting in April, we'll have a center stage and a fireside chat that will focus on technology in rehab. And then June will see the return of our much-loved debate. In the second half of our season, we'll see the second installment of our innovation challenge called Healthcare InnoMatch, and many more of the fresh and open-minded panels that you've all come to love and expect from our conference. So let's get to talking about how innovations and innovators can go from 5 seconds of fame to a lifetime of impact.
See you at CHI Innovate 2022. Good morning, ladies and gentlemen. Welcome to CHI Innovate 2022. I am Chehing, Executive Director of CHI.
And I'm Hon Tim, the Clinical Director for CHI. And together with our great team here at CHI Auditorium, we'd like to welcome you to the first of our 4-part conference series, CHI Innovate 2022.
We are so excited to finally be able to convene some of our audience here physically with us at the CHI Auditorium, while the rest of our global audience are joining us online.
The conference this year is themed The Road from Innovation to Impact, and we are pleased to bring to you 4 different installments throughout the year, and that will all culminate in a grand finale in November.
To kickstart our first event, we are honored to have gathered together eminent speakers from both within and beyond Singapore who will be engaging in insightful conversations on rehab and assistive technologies.
To our audience online and to those who have joined us live today, we've got a 2-hour session, and you can certainly look forward to 2 center stage talks, a very short and punchy fireside chat, as well as a multinational, diverse panel to round up the session today.
To kick off today's session, we have the first center stage by renowned Professor Michael Nielsen, Global Innovation Chair of Rehab Medicine from the University of Newcastle. We had the honor of hosting Prof. Nielsen a couple of months back when he was in Singapore. And so even though Prof. Nielsen cannot be with us today, we have managed to capture his insightful presentation followed by a fireside chat. So without further ado, let us bring onto screen Prof. Michael Nielsen at center stage. Sit back and enjoy.
Today I will talk about transition to out-of-hospital care and rehabilitation to the audience. And I am Professor Michael Nielsen, coming from Newcastle, Australia. And I also have a visiting professor role with the LKC School of Medicine here in Singapore. And before I start my presentation, I want to direct thank you to the organizers, Center for Healthcare Innovation, and in particular, Dr. Lu. Thank you for giving me the opportunity to talk to you today in this very important meeting. So, transition to out-of-hospital care is becoming increasingly and rapidly more important. And we are going to cover some aspects of that transition and talk about some roadblocks, potential roadblocks, and some opportunities for technology-enabled new models of care in the community and the home setting, which I find very exciting and full of opportunities, but that needs to be managed very carefully to be successful over time. So if we start first by reflecting on some contemporary concepts that we need to be aware of, and I'm sure you all are, is that we need to not only deal with diseases and treatment, but we need to overcome sickness in a broader sense and also preserve health. Prevention and rehabilitation play increasingly important roles alongside the curative therapies, and that's something that is particularly pertinent in the transition to out-of-hospital care. So we need to also take into account the ability to bear injury, disability, anticipation of death, and to successfully integrate all of these abilities into a single person's life. And we know that the healthcare systems currently are challenged everywhere globally with increasing demand on all care sectors, combined with an aging population and a growing incidence of chronic and complex conditions, which lead to higher expectations, if you wish, by consumers and carers. So we need to focus on strategies that ensure that people can remain independent as long as possible in the home setting and stay away from hospital. So a lot of focus now is to sort of develop the community and home-based models of care and integrate it into existing models. And hopefully that will lead to successful opportunities, long-term opportunities that can help solve existing problems and also provide new opportunities for longer-term strategies, an area that we have suffered from in rehab medicine for many years. As an example of initiatives that we are seeing everywhere around the world, but I'm being a part of in Australia at the moment, is the Medical Research Future Fund has launched an array of initiatives focusing on keeping people away from hospitals. And as you can see here, as sort of representative for these initiatives, is to about reduce avoidable hospitalizations. It's to help people better manage their conditions, promote lifestyles, healthy lifestyles, and support the patient care out of hospital, such as timely care at home. So there are just some of these focus areas that we are targeting at the moment. And as always, finance and economies play a big role in the discussions, and the healthcare funders, they ask, is spending choice returning value for money? Return of investment is what they want. And the profession ask, if we go ahead with a move like this, how can we treat people in the best possible way, preserve health, and can we perhaps see synergies and get into a win-win situation where we tick both boxes? We know for sure that home care and out-of-hospital care is less expensive. It's almost a given, considering that hospital has larger organization, more staff, and more complex care interventions. And then you go towards actually higher quality of life and lower cost of care in the home setting. But it doesn't happen through a magic wand or overnight. This is a process that needs to be carefully supported, planned, evaluated, and piloted in certain areas. And I strongly believe that rehabilitation is one of those areas that lend itself for a deeper understanding of this process. As mentioned, the cost reduction pressure is driving healthcare out of the hospital and into communities. This is a slide demonstrating all types of out-of-hospital or outpatient activities. And as you could see, it's a trend that has been going for a while now, and it's a steady trend, but driven by sort of increased cost in the existing hospital systems. And the decision makers see an opportunity to hand over more responsibility to community healthcare providers and the individuals themselves and their carers. And that, I believe, in many ways is the right way to go. But if you only think about it as a way of saving money, then I think we are definitely in the wrong, tracking in the wrong way. So we need to cater for both aspects of it. Totally understand the financial aspects and the unsustainable future of bringing people to the hospitals, but we need to carefully consider what we're doing going ahead. Think about quality, and thereby it can be a win-win situation. And it has been pointed out in many situations, and some of the big business journals, they have seen that the area is really ripe for change. It's an article here from a few years back from Harvard Business Review saying that time is now to engage patients and their carers in rehab and care going ahead. And that if you wish that you give and allow responsibility back to the patients in their home setting with the right models of care, with the right technology. And it's no coincidence that the big companies like Apple, Alphabet, Google, and all of them, they have an increasing interest in this field. Excuse me. So here is a quote from Tim Cook, the Apple CEO, that they really want to focus on healthcare going ahead. And I firmly believe that the individual, the consumer, the patient should be empowered and democratize healthcare. And if the big companies here are focusing on this, we can be assured that they will invest a lot of money into this field and drive this field together with the profession and other key stakeholders. So if you just reflect a little bit about sort of where we sit at the moment with the existing more traditional approach to medicine, where we have the hospital base, and you can see here the examples where we're drifting to future and more modern approaches, perhaps based on the individual. We work in partnership, we use data to drive interventions, and data owned and shared by the patients, etc. And a lot of cost savings to be made in such a system as well, we believe. So there have been a lot of suggestions on how a care model like this could look like. And here is a recent report from Deloitte. And as you can see here, it consists of different components, virtual units built up, home, workplaces or school for education, hospitals and overnight care. Of course, they have the natural role. We have clinics and same-day care. And then we have sort of retail stores and different activities built up under there. And you have the big community part as well. And you see everything coming out from that, interventions, education, monitoring, etc. And in the middle, there is the consumer. But in rehabilitation, we have very limited resources to support extended periods, long-term aspects of rehabilitation, which we know for sure will be the case for stroke and trauma and other conditions. We are not catering enough for that today. I see this as an enormous opportunity to actually use the home, the community, and education, technology with focus on the individual, with high level of precision, as an opportunity to stretch out the rehab, recovery, and health preservation initiatives into the future. It's a sustainable model, and we should, in a very determined way, in my view, sort of embark into that journey. As I said, it's not going to happen overnight. It will be a lot of change management, a lot of people working together to make this happen. And as I say here, ongoing rehabilitation success will require continuous and individual advice and follow-up. Many challenges, many opportunities. And as I said previously, we need to more clearly put the individual, the patient, in the focus for all of this. Then we can see the opportunity to make significant leaps in care and outcomes, and also support the health practitioners to deliver care in another way. And so it's all about the people and it's all about outcomes. And if we do this right, we can save money, which be absolutely necessary to do going ahead. So we can see and observe that significant shifts have led us here. We have the hospital side, the patient needs, and we have parallel investment and development in health technology that has just exploded in recent years, and that creates the fundamenta for new models. And here are just some examples where technology can assist. It's patient insights data, recovery and rehab, assistance in daily living, and we have extension of health professional and hospital care, and patient impact and well-being as they recover at home, empowered in their own environment, which I will touch upon the very last part of my presentation, the environment and its influence on individual health and recovery. COVID and the pandemic has really accelerated the innovation and health tech development, not to say the least the telemedicine side. And I'm sure in Singapore there have been massive development, as it has been in Australia and Sweden, where is my second home country, has absolutely dramatically increased. And I don't think it will go away. On the contrary, it will continue to accelerate and build up and be refined. And I mentioned the big tech companies here, the really, really top guys, Apple, Google, Facebook, all of them, all the names there. They have, all of them, defined these areas. Consumerization of healthcare, the health data analysis and demand for AI and smart devices, and all of this leading to healthcare cost reduction and reduced burden. So this is a massive invitation to a lot of enterprises to engage with us in healthcare and research to drive this development further. They can help to develop technology, they can help evaluate new models, but never forget that it's the profession and the consumer needs in the end that must be in the focus here. We touched upon that already, that we see benefits at different levels, patients, health providers and stakeholders, different types of stakeholders, families, researchers, insurance companies is very much at the forefront, and in many cases insurers are turning providers in the current landscape, and they have all incentives to come up with new models of care and to drive that development. And I'm involved in a few of those projects in Australia where we talk about virtual rehab centers. It's a very interesting but problematic approach so far. And we must be, as a profession, rehab medicine physicians, we must assure that we stay in the focus of such processes, because if we are, and we influence the development in this space, it will benefit not only rehab medicine, but others connected specialties. And we develop principal models for this that can benefit the whole healthcare. So this is not about replacing human interaction, it's enhancing, as I've said. It's a digi-physical approach. We are not saying that patients should not come in and see doctors or the team or carers. It's an enhancement. It's an extension of your right arm and hand to monitor, find out more about your patients with higher level of precision. You can support individuals in their home setting. You can nudge and motivate, Motivation is absolutely critical, and that goes for uptake of technology as well. We must work hard on that because technology that is developed without the input of the consumers themselves will not be followed, no adherence, no compliance. So that's typically a collaboration that we need to strive towards. And here again, just some examples of where tech can assist out of hospital rehab. I will not go through all of them due to time, but you see here many interesting and critical areas that we should develop together over time. And here, that's just example. One particular area that I want to point out here is the one down in the right corner. It's the virtual reality and the metaverse that is about to develop in where we can use for educational purpose, for group activities, for networking, connecting patients with carers, and very interesting area for the future to keep an eye on and be engaged in as well. So it's important to take a systematic approach, but at the same time individualized approach. It must have, the system we are implementing must have a multimodal core, must be treatment centered, and be evaluated with ease. I mean, everything that you strive to understand, you are motivated to use, and it's easy to use, will eventually be used. So technology heavy, complex, difficult to understand solutions are not winners in this landscape going ahead. Simplicity, low-hanging fruit to start with, get good examples and take it from there. Build systematically from bottom and up, and don't overdo it because we risk to kill the whole area. So insights and automation, one point of contact. We don't want data to be spread everywhere around one and the same patient. It must be a one point where you can understand what you collect from one and the same patient, and the data should be automatically collected, and then you need to help understand and treat the patients based on what you bring in. You create, if you wish, some kind of digital phenotyping here. All the data that you bring in together with what you know, create a digital footprint and a individual health map that you can build on and tailor the intervention from a biopsychosocial perspective going ahead. So again, I just want to point this out that it's critically important that we take a human-centric approach, inclusive, that we have consumers. The big tech companies understand that completely, and they are engaging patients, consumers increasingly, just to get the right interface between them and the right motivational drive. So we can, it's a bit repetitive here. So there are challenges, as I mentioned, in the system, and for all stakeholders involved, the health providers, the patients, other stakeholders, technology providers. And these defined and experienced problems, they are there to be overcome, and we need to work together. And when we discussed this before, Dr. Loh and myself, we had a totally united view on how difficult it will be. Challenging, full of opportunities, but we need to realize that to implement technology that it's targeted to the individual, the technology side will eventually be the easier part, and the change management will take up most of the time. And we need to understand that we need to allocate energy, resources, and be persistent over time to make this happen. So that's a thing that experience tells us so far. And in this context, it's also important to perhaps point out that we will be absolutely overwashed by new technology and opportunities. And for the individual and for everyone in this ecosystem, it will be a challenge to pick what you need and what's best for me, what's best for the context. And therefore we see development of new companies, new emerging SMEs in this space, focusing on selection of the right technology. They have very advanced algorithms, so they can screen the horizon, they can screen the landscape, and they can come up with tailored advice. And one company like that is called HelloEd, and it's a company that I work with in Australia. It's a developing company, developing concept, but I just want to point it out that that might be a niche that needs to be filled going ahead, because it's not going to be easy to pick the winners or pick the right solutions going ahead. The last part I'm going to talk about and briefly touched upon is artificial intelligence in healthcare and in rehab going ahead. We have yet another statement here from the Google CEO, as you can see. Here are some areas that we at the CRI in Newcastle currently are focusing on: personalized solutions, home-based rehab, and also stratification tools, AI-supported clinical decision support tools, and economy around that, and automatization of patient data. And then finally, we're also focusing on healing environments, architecture and design, and its role in health preservation and rehabilitation. We, in rehab in general, we suffer from lack of understanding of the individual needs at a deeper level. We of course fall back on our clinical experience and what we have learned, our professional knowledge and all of that. But the pace in which we operate in healthcare today doesn't allow a deeper understanding of the individual. So clinical decision support tool can actually aid in the decision making and stratification to the right care level, and contribute to what I've said, precision rehabilitation, and also allocation to resources and move to the right care level. So we are currently developing a tool which we also try to understand the economics of the process, and what we predict is that we will have a more accurate patient selection. This is after total knee replacement and rehabilitation, either in the clinic or in the home setting. So we are following at a different level, as you can see here, and we are in the middle of it. We have recruited 1,000 patients out of 1,200 patients for the model that is conceptualized here and this can be implemented in any area. It's a principal flow leading all the way from unmet clinical need to impact. And we are using specifically designed algorithms and machine learning to help us with the stratification and the care level of individuals. And in this very project that we call SuperKnee, we have collected this data here, as you can see. It's a broad biopsychosocial perspective. And we are currently in the finalizing phase. The algorithm is developed, it's working, and the preliminary data that we have analyzed looks really promising. So during this year, we will be able to have a view on this very project, and we are all very excited about it. So very little consideration has been given to designing homes and home interior that can support healthy aging, prevent falls, or even through multimodal stimulation can stimulate the brain and its plasticity processes to actually work in concert with interventions. And neuroarchitecture is a movement that is increasing everywhere, and most of all in the US, where they have started an academy for architecture and healthcare. And healing environments build on the concept of enriched environment and how the multisensory stimulation actually can create better opportunities for the brain to reorganize. And there have been a lot of publications recently in this space, and this is a book that I wrote a chapter in last year. It's called Architecture for Residential Care and Aging Communities. And I think the editors of the book here have summarized it very well, and that is that the demand on the housing will change and develop because we see increasing needs for home health care, and we will need to rethink the healing environment approach in our healthcare design, architecture, and our interior as well. And this is an area that we haven't really considered from a healthcare perspective, but it's very, very exciting. And by that, I would say thank you, and thank you for taking time to listen to my presentation. Thank you very much.
Hello again, ladies and gentlemen, and to those of you who have just joined us, welcome to CHI Innovate 2022, and this is the first episode in a 4-part series that's going to last throughout the year. So to our online audience, and also to our live audience, believe it or not, we actually have a live audience here for the first time in 2 years. We hope you enjoyed that talk, that center stage talk by Professor Michael Nielsen. And coming up next, we're also going to bring to you now a recording of a fireside chat that Prof. Nielsen had with Dr. Lo Yong-ju, who also happens to be CHI's very own Associate Clinical Director. It was a great conversation, so please enjoy this chat.
Thanks, Prof. Nielsen, for your inspiring talk for our CHI Center Stage event as part of CHI Innovate. Actually, I wish I have 1 hour to ask you, but I only had 10 minutes. So we will keep it to some of the succinct points that I hope to actually see your insights on, because really the talk is very much aligned to what we are doing in CHI and Tan Tock Seng, and hope also relevant to the whole nation. So I just wanted to look at 3 points for us to discuss during this fire chat conversation. First is about the culture of innovation. How do you build it upon our providers, and also have partnerships with academics and industry that is relevant to our patients and our other stakeholders? That is the first question we hope to discuss. Then the second point is, what are the essential processes that you think can help us translate rehabilitation technologies from hospital to community? And last but not least, if we have some time, let's look at this question on the paradigm shift towards adoption of technologies in the community, and how do we actually drive that force forward? Okay, Prof, over to you.
So thank you for your kind words and introduction, and those are highly relevant questions, of course, that each one could take up hours of discussions,
yes,
as you
correct.
say. And I want to reconnect to a few things that I said in my presentation, but the first one around culture and how you can engage providers and different stakeholders in the system. That's a critical question, and absolutely essential to to create that base platform, because it will be the fundamental part going ahead. There will be no single individuals that can do this by themselves. It's essential to bring in different expertise areas, different individuals with a passion for change. We need to, if you wish, create a task force that is dedicated to build an ecosystem where we have, naturally, the health profession, but we need technology, we need engineering, we need computer science, IT, we need perhaps education, as you mentioned yourself earlier. We need architects, perhaps, and we need psychologists that can help with behavior change and adaptation. So that is to be defined, but I think it's very important that we can't cut corners in this process. So it's about building a culture that is long-lasting. and you need to have the right people, the dedication in the people coming on board there.
Okay, the second question on the processes, because it's something that we also have some challenges locally
Yeah.
about some of the considerations. I think I did mention in some of the other smaller conversations we had that there are a lot of factors to look into, especially currently with the data security considerations.
Yes.
And also quite a lot of governance and also requirements for us to roll out technologies,
Yes.
even in the institution setting to the community.
Yes.
So any insights you can share in your country that actually works, that actually you're able to push some of the technologies forward earlier?
Yes. I think it's important to start different processes in parallel, because there are delays and current and existing silos, and you need to, as I said, open up and create transparency and build trust among the people involved. But I think it's essential to select a pilot area and to prepare the introduction as much as you possibly can through modeling. But there comes a time where you need to go in and create some kind of distributed living lab, meaning that you need to work with people in their home, and you need to try and tailor solutions and not do everything at once. Just try to take a rather simplistic view and monitor some areas, monitor sort of what you find most interesting and could be easily implemented first. And there is a big component of learning by doing here.
Yes.
And then evaluate and see what was successful and not. But again, it's a lot of preparative work, and cutting corners in that process will lead to failure, I'm sure. So, but there are also a distinct point where you need to say that we need to test this. We need to select a pilot cohort, and I repeat again, I think rehab medicine is a very, very strong candidate to be the pilot area.
Yes, you're right to say that in rehabilitation locally, we are also trying to do that. Because we are trying to look at a person-centric approach, right? To design technologies and also programs.
That's right.
That will cater to a particular individual disability and also functional needs. So it's really quite crucial for us to, I mean, of course, have a so-called sandbox to actually test some of the pilots in order for us to move another step forward.
That's right.
It's just that currently, like I mentioned, there are quite a lot of processes for us to go through that we hope to actually learn from some of the insights that you had in Australia. So that is the part that we like to look at. So I think I really agree with you totally about this 80% change management and 20% technology. I think the change management is the whole healthcare ecosystem.
That's right.
And also includes the community that will help us drive innovation and also technologies forward to the community. So that's why that comes to my last part, which is the paradigm shift, right? That we all like to move towards. And what is the future healthcare like when we go into improving, like you mentioned, health in the population, and also looking at let patients be more self-motivated to actually take care of their health. Is there any so-called some insights or pearls of wisdom that you'd like to share with the audience with regards to this?
There certainly are important insights that relates to the systems that it will take place. And here in Singapore, you have your unique opportunities, abilities, but also your unique roadblocks. And I observe them in Australia and observe them in Sweden, US, or wherever you look. So it's important to understand all of them as much as you possibly can. That's essential, because otherwise you launch and you come up against problems. You will do that anyway, but problems that could have been predicted. So that's again doing the job carefully before you roll out something. The other one that I'm strong about as well is to engage the consumers, the patients, early on, because traditionally we have not been very good at doing that. We have come up with solutions that we tell the patients that this is good for you, and the technology has been developed, said this is good for you, but then when it's coming to the home, no one's using it. So I mean that I have a great deal of respect for that part of it. It come back to ease of use, motivation, precision, having the individual in the center, and then it is imperative to have the leadership of the different organizations that backs an initiative up like this. They must be committed. It's absolutely important. Otherwise, you sooner or later will be up against problems that you can't solve.
Yeah, correct.
So, and all of this, I understand, I have respect for it. It's easy to say, but it needs to be there. This is potentially a transformational shift that we are a part of, that can change healthcare for years to come. It's important that we bring it on board and treat it sort of with our full focus.
Thanks so much, Prof. And thanks again, Prof. Nielsen, for joining us in this CHI Center Stage event as part of CHI Innovate. Thanks so much.
Thank you, Dr. Liu. It has been a pleasure. Thank you.
Good afternoon, ladies and gentlemen. I'm Yongju, the Associate Clinical Director of CHI, as well as a Senior Consultant in Rehab Medicine from Tan Tock Seng. As the moderator of this upcoming panel discussion, may I invite our esteemed panelists to join me on stage, where we will talk about rehabilitative and assistive technologies innovation translation, quite a mouthful. So we have an acronym called RATIONAL. When will we be ready? Panelists, please. Okay, for the audience who just joined us, let me make sure that the panelists are well seated and comfortable. Okay, we have on our left Associate Professor Wee Seng Kui, a Senior Principal Physiotherapist from Tan Tock Seng, who just inspired us with his sharing on CUT Team 1 Million Exoskeleton Steps Achievement. Next to Seng Kui is Mr. Zhang Ko, co-founder and Deputy Group CEO of Fourier Intelligence. Followed by Dr. Karen Chua, Senior Consultant from Tan Tock Seng Rehabilitation Medicine. We also had the pleasure of having Ms. Alexis Loh, Head of Rehab and Wellness from Stroke Support Station. And last and definitely not least, Dr. Shamala, who is the President of Singapore National Stroke Association, also double head as the Principal PT from Singapore General Hospital. Welcome, panelists. Okay, so welcome everyone to CHI Innovate 2022 team, The Road from Innovation to Impact. So in this upcoming 1-hour panel, we would like to keep this panel as interactive as possible. We will be inviting the audience to participate in two polls so that we can all pull together our interesting insights collectively to scale rehab technology into the community. But before we dive into the panel, allow me to pose 2 burning questions to you, Seng Kui. Okay, I'd like to find out, number one, how do you motivate your team towards achieving the 1 million steps together within such a short time?
So thanks, Yongju, for the question. Now, yes, we need to build up such a clinical services from day one. And what better way to actually encourage each other is to try out the exoskeleton therapy in different patient groups, such as those with stroke, spinal cord injury, traumatic brain injury, multiple sclerosis, as you have seen from my presentation. And with each individual who had gone through the therapy, we analyze the outcome, understand what's actually happening. And when my colleagues actually observe the change, the positive change in the patients, they're further encouraged. That's how we continue to support each other to say, okay, let's analyze this case. Is the individual going to be benefiting from such a technology? I just want to add that not all patients may benefit from it. You have to assess the patient's medical condition, as well as listen out with regards to their goals that they wish to achieve and see whether it's achievable. Then that's when you pull in the right technology to support such an individual. So over the time, over weeks, months of working closely with my fellow colleagues, and we do share case studies along the way and brainstorm how best to improve their therapy program. So when we learn as a team, that's how we continue to encourage each other to achieve that numerous steps for patients.
Thanks so much. Yeah. So second question, from your perspective, what do you think will be the potential of bringing these mobile exoskeletons to homes and the factors that you think will be important?
So I think to make that materialize, I think the price of the technology has to drop first, right? So it's a chicken and egg thing. I mean, if there are more adopters of such technology, then the price can decrease. So that it makes it affordable for all individuals who may benefit from it. So I feel that's one of the key things. Now, secondly, the patients with various conditions also has to undergo similar therapy in the clinic. That's when the therapist can decide, is this going to be good for you when you take this home or purchase one to be used at home? So much like the Israel Rewalk, wonderful mobile exoskeleton, the patient cannot just buy off the shelf and off they go, or buy online for the matter. In fact, they make it very strict that the potential buyer will have to receive 6 months of training with the therapist in the clinic so that they make sure that all the safety aspects are taken care of, and the carer knows how to operate it safely. Then, Rewalk company allow this individual to purchase a personal set. So going by the same model, I feel that we can learn from the Israeli side and see how best to fit within the context of our healthcare system. Can healthcare insurance support such exoskeleton? So I think clinicians need to prove that clinical efficacy very strongly to our healthcare insurance company to say, hey, this has benefited the individual, and we have really worked through the individual with exoskeleton for a good half a year. I think it's high time that this person needs one. Okay.
Thanks so much, Seng Kui, for your answers. Now, ladies and gentlemen, I know all of you are itching to actually pick the brains of our panelists joining us here today. So we all know there is no shortage of rehabilitation technology systems in Singapore, but how ready are we as rehabilitation professionals to ensure patients are well supported to embrace and adopt tech-enabled models of care? And how do we then keep the tech-enabled rehabilitation service sustainable? Our 5 panelists and the audience joining us today, I would like to give you a 15-second challenge. We would like you to give a scoring between 0 to 10 on how ready do you think we are at rolling out tech-enabled rehabilitation in the community. 0 being not ready at all, 10 being very ready. Audience, do give your scoring and use the Zoom poll function. And panelists, do take the paper and pen in front of you. After your scoring, each of you will then share with us reasons for your scoring. So everyone's ready? Your 15 seconds start now. Okay, thumbs up. Okay, so let's see the responses from the audience. Wow, it's mostly about 6. Still going up. Okay. Oh, that's a quite interesting response. Let's see the panelists. What are your scores? Wow, 6, 8, 8. Wow, so the panelists generally is higher than the audience. Audience about 6 to 7. Wow, the panelists is about 7 to 8, 6 to 8 also. Okay, interesting. Okay, let's us maybe start with Shamala. Okay, so Shamala, why do you score? Yours is what again?
6.5.
6.5. Okay, you added a 0.5. Okay, Shamala, please let us know why you scored that.
Thanks, Youngju. I was tossing up between 6 and 7. Yeah, between 6 and 7, so I decided to draw in the 0.5. Generally, I feel that patients are keen to try new interventions or new mediums of delivering therapy. And therapists themselves are open to new ideas that they can offer to patients. But I guess what needs improvement, with CHI leading the way also, is how the infrastructure can support the patient and therapist choices. I think that would explain why I gave a 6.5. Infrastructure, not only in terms of what Senkwi said about costing, but also models of care, training, and perhaps different utilization of our manpower. And when we talk about truly moving from hospital to community, do we just stop at the ILTC sector, or places like Sports SG and People's Association could also be a means of provision, depending on which technology we're talking about. So I think it's exciting where we're headed with CHI leading the way, but there's so much more work that can be done for the infrastructure to allow the growth of tech-enabled rehab in the community.
Thanks, Shamala. Alexis, over to you. What is your score, and why do you score that?
My score is 7. Okay, and basically this number is an average of 2 sub-scores. So it just depends on the type of technology that we're talking about and who it applies to. So I've broken it up basically into 2 categories. So for technology that is generally affordable, effective, easily implementable, easily accessible, then that kind of helps to take this technology a little bit closer into the community. But I've also spoken to several organizations that have adopted technology, and also to several therapists as well. And I've been very encouraged to hear that many of the therapists are actually very open to adopting technology, even at the community level. So a lot of the therapists are keen to try out new devices to actually see whether their therapy sessions are effective, or to see how applicable they are in the lives of the clients we see. So that itself takes my score to a 9 out of 10. It's a no-brainer, right? If it works, it's easy to apply, and people are keen to use it. But then I also understand that there's another range of technology out there that is a little bit, that comes with a higher price tag, and it's more complex to use. So for this group of technology, there are actually quite a few barriers to implementing in the community, and I'm sure there's quite a lot more than I can bring up right now. I think Senkwi has mentioned a couple of barriers as well, but just off the top of my mind, one is, in the community level, we know that technology has been adopted far later than in larger institutions that have had the opportunity to be test beds for several complex, advanced type of technologies. So overall, in the community, I find that there's a general lack of clinical expertise. Of course, over time, there's been more and more community rehab centers that have been adopting technology, but it's still lagging a little behind the acute hospitals, right? And then on top of that, in Singapore, we are also facing a national shortage of therapists, and that places quite a strain on the rehab, the community rehab sector. Because when we are talking about complex technologies, often it comes with specialized training, even certifications. So in the community sector, if we are short of therapists, it's already a limiting factor when it comes to provision of training, and even the use of locum staff will also be prohibitive to a lot of the training opportunities and translation of the clinical knowledge. So that is also another barrier. And on top of that is the cost. I think we can't get away from that fact, right? So again, funding to support such models of care is still currently a little bit limited. And then lastly, I think also as mentioned before, there's such a wide variety of technology available out there. So for community rehab centers to decide on one particular or a few particular technologies out there, it becomes a decision that has to be weighed very heavily because we have to consider the longevity of the effectiveness of this product as well as the relevance, especially if we consider how rapidly evolving the development of technology is. So for that, I've rated it 5 out of 10. So on the average, we have score 7.
Wow. So Leslie is able to register in her brain on all the scores, then average is 7. Well, that's very good. Dr. Chua, what about you?
Can you hear me? Yeah, so I think that, our ecosystem is really quite empowered right now, right? We have many sources of funding for translation. We have actually many of our engineers in academia and in industry who are very cued into the issues that we have. So I think our panelists have brought up the issue of a worldwide shortage of therapists. COVID hasn't made it easier because people have been deployed in areas that are out of their primary field of care. Now we're hoping to get people back in again after 2 years. Singapore being one of the most wired nations with 99.9% penetration of mobile devices, our patients, even though the slightly older ones, are actually quite empowered. They are learning ICT technology. They are very happy to Zoom with the doctors. To be honest, patients whom I thought, I don't think this guy can do it, Zoom. Actually, I'm really surprised. I've actually put one of my oldest patients, somebody I didn't think could, and the experience of looking at this patient across the Zoom was so gratifying. I saw the patient in a natural environment. Even a bed-bound patient with the family was so happy to wave at me from the bed. And I said, the problem is not the patient, the problem is with me, the clinician, that I've actually put a glass ceiling on the patient that they could not actually cope with ICT technology. So I think that on a social level, our patients are ready. Many of them actually say that, I'm really bored with this. Can I do something more? Can I try something different? So I think we have a high penetrance of technology in the various aspects of our healthcare system. I do agree with Shamala's point that there are variable levels of consistency in how we actually translate. Some acute hospitals are very busy, and therefore, it's not that the therapists don't want to, they have no bandwidth. And I think that, very often we say that technology helps us to improve productivity, reduce manpower. But I think that with CART's 10-year experience, what we have actually learned is that if you want to implement a technology, you want to deploy, unfortunately, in the first few years, you do have to invest that manpower. You could need to invest about 0.5, etc. So taking the example of EXO, we've had EXO since 2019. And honestly, when we planned the service, we said we will need an additional 0.5 FTE for probably the first couple of years to learn, to orientate, to disseminate, collect outcomes, look at the whole governance process, look at the whole clinical process. And after that, actually, hopefully we actually see a second generation of EXO trainers coming in our center, and hopefully we actually see so-called a continuation and expansion of those gains. So I've talked about the patients, I've talked about technology. Now, I think there are certain bumps along the way because clearly we've talked a lot about cost. We've looked at cost very traditionally as a purchase model. It goes into capex. You have to do a lot of rounds of approval and all that. But I think nowadays, industry is actually coming in to look at robots or technology as a rental service model. So this is another interesting thing that we need to explore more, because clearly I think companies will need a balance of both. Some you purchase and some you actually rent. And the rental model actually may be slightly more palatable to more of the industries. And of course, how it's actually, more of the consumers, how it's actually funded is another issue. Because there are some caps in funding, and we all know that technology is considered non-subsidized, right? We have a very small subsidized stream in Tan Hock Seng, which is really a threat. It's probably about 10 to 15% of our patients who could access it. And of course, another sector we have not actually engaged is insurance, right? And now we have an increasing number of patients who have insurance policies that carry on for 6 to 12 months after discharge from a stroke or from an accident. So I think there are many untapped streams that we could explore. And clearly, I think that we need a lot of communication with all the stakeholders. And I do see that we have that fragmentation, which despite many MOUs, etc., we are still a bit fragmented. Perhaps, actually, I think the data-driven approach could help us, meaning that if we have a technology that's flowing from an acute hospital to, say, S3, for example, and we actually are able to have a common data platform that looks at monitoring of usage or how patients are doing, we'll have a better idea, and that will prompt actually a conversation actually with across the sectors. Thank you.
Thanks, Dr. Chua. Zen, what is your score?
My score is also 8.
8.
Yeah. So
wow. Prosperity. Okay.
yeah. So we can buy the lucky numbers. No, just kidding. So yeah, I guess I'm one of the only technopreneur within the panelists. So I want to echo the fellow panelists, the points that they brought up. So I started off as an engineer. So when we developed technologies, very piecemeal back then. We have like different technologies for different purposes, upper extremity for the OTs, lower extremity for the PTs, etc., etc. So you go into the so-called the rehab clinics, you will see a lot of different products, technologies, and companies trying to solve different kind of problems. So like what Singkui mentioned, exoskeleton, there are 165 companies, institutions working on exoskeleton technologies alone. Even Korea, we work on 3 kinds of exoskeleton for research, for medical, and for home base. So all of us, like what Karen mentioned, there are so many different stakeholder groups trying to do different things by ourselves. Actually, we are reinventing the wheels. So when we started third year, we want to do something different. I think the key word is accessibility. What are technologies when it cannot be used in a clinical setting, it cannot be used in a community setting, it cannot be used at home, and it's so complex. One example that I like to use a lot, like the Apple iPhone. If you buy an iPhone and you have to take 2 days of advanced training and 6 months of advanced training, like one of the products that I sold to Singkui, so I guess you will probably not use the iPhone. The first smartphone came out. It is huge. It's the, they call it like the for the only really rich people. They actually had to employ someone to carry the phone for them first. Yeah, but now actually we all have 2 or 3 phones. It's called smartphone. And I think when Steve Jobs launched the phone, he didn't anticipate that so many people develop apps and usage cameras and different features, right? So Fourier decided that we cannot build everything ourselves. So we work with 30 global partners, some of them companies in the business for 30 years. We work with researchers, 17 joint labs worldwide, we just ink an MOU with TDSH. Because we realized that we need to work with clinicians, engineers, companies, researchers, even the patients themselves, to make technology accessible, easy to use, so that we don't spend hours setting up the patients, but using the time to give patients the intensity, the dosage, the repetition, which are the key. And of course, we think that we are successful in some ways because we went to one of the toughest market, the largest market in China. So we launched the community setup, and we were quite successful. For the last 2 years, we managed to go to even the villages, and the community setup has been really successful. I think the future is not trying to make one piece each for each of the solutions or problems that we need to address. The future could be, and that's what Fori is trying to do. Through an open platform system that we launch, we acquired companies and core technologies to try to build, and this is a bit far-fetched, future technologies. Imagine, like, Elon Musk tried to do that, the humanoid robotics. So a human-like robots that can do what Sync can do. And basically, you just have one Sync look-alike humanoid. We make your face. You can move the hands, move the legs, and do everything. Maybe that could be the future. So you don't need to have so many different kind of technologies and products. But that is the future. With AI, with robotics, maybe we can solve all the problems that Sync just mentioned.
Yes, I think a lot of movies had that happening already. So we really hope that in the near future, Fourier intelligence will help us make that happen. So, Sync, what about your score and why?
Score 6, I think, sorry, okay, yeah. Okay, how ready is the community and all that? But I think we have to create more awareness to begin with. Then I think our patients with various disability knows the existence of such a technology and can look out for the service providers, be it in the day rehab center or in the home therapy kind of setup or in the major hospitals. Then can they request their doctors for referral, for the therapists to assess for suitability, and that's how it will roll. Otherwise, if you survey the general public now, how many of them may be aware of existence of such a, say, the exoskeleton, or even some virtual reality systems that they can use to exercise? Maybe only a handful. Yes, by and large, we are in this era whereby smartphone exists. People are used to technology. So the question is, do they know that right technology exists to help them to recover better? That's the other thing. Hence, through platforms such as this and through various media is to create that awareness to begin with. And then people will start to realize, oh, okay, there could be something out there that can help me. Then they will start knocking doors. Yeah. Say, for example, when I Photoshop that photo of walking this lady to the MRT station, that's my dream. And in fact, that patient is so nice. She wants to create awareness as well. She knows the challenges. So she said, hey, let's do a flash mob. Let's walk me into an MRT and just don't need to tell anyone, no need to tell your comms. Just let the public do the talking. Right, can you imagine? I walk that lady into an MRT station and just take a trip downtown, walk her into a shopping mall, sit down, have a meal with me and her family. Isn't that good enough to spread the word? So I think the general awareness of different types of rehab technology may not be quite there yet. That's why I score it a little bit lower.
Thanks, Ingrid. Really, when we design things, we always want to have the end stage in mind, right? What do we want our patients to do? And also, most importantly, involve our patients in what they want the technology to do for them. Okay, so everyone from the scoring above, what do you think is the greatest barrier now to the translation of tech-enabled rehabilitation from hospital to community? So again, signal to you all. We are now given about 15 seconds to write down your answer, and audience also 15 seconds for you to select what do you think is the greatest barrier to the translation of tech-enabled rehab from hospital to community. So we're only given 3 here: patient acceptance, clinical efficacy, and IT constraints. Of course, not an exhaustive list. I know just now the panelists has mentioned much more, funding, etc. But both panelists and audience alike, you may only select one answer just for this session. Okay, so 15 seconds start now, right? Yeah. Greatest barrier. Okay, wow. IT constraints. I'm not really surprised. Okay, Seng Kui, would you agree with the audience identification of IT constraints?
Yeah, I agree with that.
Yeah.
Now, so take, for example, we did a clinical trial on the efficacy of a virtual reality system 3 years back. But do you know, it was such a tough battle for us to even push out to the homes. It has clearly shown to benefit patients, but we were hindered by our IHs, right? They talk about cybersecurity and all that, which is real. We recognize it is important, but that truly is something that we need to talk through and overcome. We recognize the importance of data protection for patients' sake, but likewise, we got to see how can we work around on the IT backend to make it even safer so that it's acceptable by our IHIS, fellow colleagues, right? The other aspect is we all have done some form of teleconsult during this COVID pandemic. We recognize that some family may not have very good Wi-Fi, for example, so internet breakdowns, etc., can cause certain communication delay, and with that, it may frustrate some individuals as well. So I think looking beyond just clinical evidence is there, right? Everyone knows, but I think there's still room for improvement in improving the technological IT support aspects. Yeah. Likewise, if you want a patient to use a certain form of technology in their own homes, we need to inject in a very good responsive technical support. So for example, in that virtual reality trial, the vendor was very responsive. When there was a technical glitch, within 2 hours, he's down in patient's home to rectify it. Such a patient can still continue the virtual reality tele-rehab exercises at home. So this is just one example. If you ask me, patient acceptance-wise, like I said earlier, nowadays people are more open to various sorts of technology. So even with my older patient, close to 80 years old, when we show them the videos of exoskeleton and describe the benefits, yeah, you'll be surprised that older people are just as open to technology nowadays. Thank you.
Thanks, Seng Kui. I think, Zen, I saw that you put complexity, which is maybe a combination of these three. Okay, I am sure you have plenty of initiatives from your NTU days to even for real intelligence now. What with your one all-time favorite project that you want to share with us, and what are some of the success factors and challenges in doing this project?
Well, actually, I can link it back to this question, the IT constraints as well. One of the favorite projects that we have been working on is to do the remote rehabilitation. So 5G is available in China now, so we had a collaboration with the Beijing hospitals. So some of the robotics, we want to let it interact with each other so that we can do group therapy. Like you mentioned, lack of therapies. Can one therapist manage 3 to 5 patients using multiple devices so that their time are freed up to do better assessment, diagnosis, prescription, dosage, decision, etc. So even better, can we do it during the COVID time remotely? So we tried very ambitiously from Shanghai, 3,000 kilometers away in Xinjiang, using our device, using haptic feedback, so the therapists can move the hands of the patients remotely. The patient is strapped on another machine, actually feel exactly how the patient reacts. The spasticity, I can feel it, so I can actually respond. So the latency is bare minimum. But Seng Kui mentioned about IT constraints. Not all countries or regions have that kind of access to the technologies. Like in Spain, we try to do the same thing, but we can't because they block 5G for certain reasons. So the latency becomes very bad. So we cannot do that. It took us some time to let the machines be able to interact and create a group therapy kind of concept. It took about 2 years to actually kind of like get it ready. So we're quite proud about it because now a lot of the hospitals now in Asia, they are able to have 3 to 5 machines, not the same kind, different kind. And actually one therapist can work with them on site, even remotely as well. So I think this is the project that we are quite proud of. And we talk about it for quite some time, but finally we are able to do it, yeah.
Thanks, Dan. Really, tele-rehabilitation is what we hope to move forward, to do remote monitoring of patients' progress and also bring technology from hospital to homes. So different assistive aids will be required to do that. Okay, So perfect for the next question to Dr. Karen Chua. So, I mean, Dr. Chua has been amazing in looking at different technologies from co-development to implementation of the technologies in rehab. One of the robots that Dr. Chua has co-developed is Hitchman. So with this project, what we say is the greatest potential and also the key challenge and barrier when you translate all your research work into products and services to enhance the current rehab care continuum. Dr. Chua, please.
Thanks, Yongju. So as many of you know, we had the privilege to partner with NTU way back in 2013, and it was actually supported by an NMRC grant, and we managed to kind of co-develop the robot and test bid it with NTU. So we had 60 patients in all, of which 44 of them went through an RCT. So that was each man with conventional therapy in a clinic setting. And the patients had about 18 hours in all, and they were compared with the dose-matched conventional therapy group. So no surprises. We were not surprised that the robot performed quite well. And in terms of the results, the Hitchman had a slight advantage, but it wasn't really statistically significant. So we actually expected those results, because if you look at the literature overall, you will get equipotent sort of response whether you do conventional therapy with or without robotics. So, but the important thing about that trial was that the patients could exercise with lesser supervision. So they didn't really need a therapist with them all the time. So the advantage about this device is that it's really quite portable. It's 14 kilos. And I think the new version now is about maybe 12.5 kilos. So it's like a bag of rice and a little bit more with a freebie. And it just has a screen and some connections and a plug into the wall. That's it. And of course, the handle is just plug and play. So in that trial, we managed to have 4 patients bring the robot home. They were exercising with the engineer in the background, and it was just a 3-day trial, and they brought it back. But right now, we're actually testing the robot for what we call a tele-rehab robotics trial. So they bring the robot into the house. They are on their own with their carers or their spouse or caregiver. Therapist does not go in, but we actually remotely monitor them through a cloud platform. Okay, and we can look at the data generated by repetitions, duration, amount of forces that they're actually using. So that is the greatest potential of Hitchman, that it's lightweight, it can be brought home. It's also a lot cheaper than your usual complex robotics. How much cheaper? Maybe it costs about 30 to 40% off the price of a similar, say, product made in the US or in Europe, for example. So that is actually the main advantage, that it can penetrate, and clearly the vendors have actually been able to, before they actually entered Tan Tock Seng, they actually went off to nursing homes and they went off to the community. So actually the first point of care where it was used in clinical trial was not in the acute hospital. They knew that it would be difficult. So nursing homes had it and DRCs had it. I think a couple each actually were using it quite well. And of course now we actually have it in our center as a clinical robot for treatment. What about the challenges? I think that when we look at tele-rehab, we are in a whole new sphere. I think a lot of tele-rehab has to do with portable devices like the hand, virtual reality, games, commercial gaming platforms. That's actually where, as Zen was mentioning, you need to have that 5G or very good network. Once it lags, you have a problem. And then the patients get very unmotivated because they see inconsistencies in being able to engage, and performance may not be uploaded, and these kind of things. Conversely, when you actually have a robot that goes home, there are good and bad points. So one is that you need to deliver it, right? So you can decide, either you deliver it with the vendor, the therapist may or may not need to go to the house. But the good thing is that the robot can perform in a low Wi-Fi environment. So you actually don't need Wi-Fi. So you can have a Wi-Fi shutdown. The robot's happy because its games are all there. Wi-Fi comes back on, you upload the data, right? And then after that, therapists can look at it on the other end. So there are plus and minuses actually on both ends of the coin. The challenges I actually see is to make sense of the data. Now there's so much data that's flowing out to us. We have to understand actually the data behind it. And this is where we really need to sit down with the engineers, get our fingers dirty, and really understand all the numbers and the maths that's actually coming through. So that part of it I find is going to be a challenge, but it's a happy problem. And I think the last thing, of course, is everybody is talking about who pays, right? So the question is always who pays, right? At the end of the day, it's never going to make a dent in our clinical sphere unless we settle this question. And I think we'll probably need another 3-hour discussion to actually figure this one out.
Yeah, thanks, Dr. Chua. Yeah, I think a lot of issues is about payment and also some of the considerations for data. Really, HMAN really illustrates how we can bring hospital-developed technology to the community. And we do need to also look at partners that we can partner with, especially with S3, SNSA, and also continue to work with FORIA in a way to look at how we can develop new technologies that can be used in hospital to community. So now to Alexis, over to you. Okay, what have you identified as your greatest barrier, Alexis? Also IT constraint or? Cost and funding.
Yeah.
Okay.
And I won't try to delve deep into
no problem.
what
Yes.
Dr. Karen Chua has just brought up. But yes, it's always in the minds of the end users, right? And here, I think on this platform, we're really talking about how technology can be translated into the community, not just for the service providers, but actually the end users in their homes. Right, and so from speaking from the ILTC perspective, ILTC meaning the intermediate to long-term care, essentially for those of us working directly with clients in the rehab setting in this sector, we're really talking about providing rehab for the long term, right? And a lot of us have that challenge of working with clients being the last stop before they're on their own, okay? In a very simplistic manner, of course, we try to provide a lot of community services to support people with disabilities and their rehab needs. But what I would like to really talk about is actually how important it is for the ILTC sector to really think about how we can bring up the quality of care, making sure that the clients are rehabilitated to the best possible level so that they can actually reintegrate back into their families, their workplaces, and their communities, right? So that's really kind of the ultimate goal for all these interventions that we're talking about, right? And I feel that what is really kind of missing in that portion is how we translate all these wonderful, exciting technologies from our treatment, the gyms, the centers, into the homes, so that it's eventually something that can continue on for a long term. So I come from a stroke support station, and we work with clients that have long-term disabilities. And yeah, we have a lot of experience there too. So, we understand how important it is to support them for long term, right? And right now, more and more community rehab centers are bringing on technology. So we have clients that are beginning to experience the benefits of technology. They're excited, they're engaged in it, and they see, most of all, they see the effects, how it's helping them functionally. And then we have to come to a point where we have to discharge them. And what do? We send them home with an A4 size paper with their home exercises, right? It doesn't really work very well, especially for clients that have been working with technology for a while. And of course, for also on top of that, for lack of better alternatives out there, once we discharge them into a community, what is there to fill that portion, right, to bridge them home? So technologies come in very handy if we're talking about tech-enabled rehab post-discharge, or even for clients who are working towards close to discharge or as an adjunct to the therapies they're having in the center, then we need to figure out a way to make these tech-enabled rehab devices accessible. And one of the limiting factors, I feel, and the barrier is actually the cost, because at the end of the day, exactly the million-dollar question, who's going to pay, right? Is it a service provider? Is it the clients? Ultimately, there is quite a big price tag, and most of our clients won't be able to pay out of pocket. So I find that the biggest barrier is really like looking into this support to make it accessible, and apart from funding, it's probably also the need for further evidence to prove how effective tech-enabled rehab in the home is going to impact the healthcare outcomes, because ultimately we're trying to keep these people who've gone through rehab to stay well in the long run, again, to help to reduce healthcare costs. So I think these two factors go hand in hand together, and hopefully with that, we can eventually see technology creating an impact, not just for the clients, the end users, but also for the healthcare ecosystem as a whole.
Thanks, Alexis. As Singapore is a very affluent country with an aging population, we are getting more and more stroke patients through the years. So besides having stroke support station, we have the Singapore National Stroke Association, which is also advocating for stroke survivors out there in the community. So Shamala, being the president of the Singapore National Stroke Association and also a very, very well-known practitioner in Singapore General Hospital, what do you think are the biggest gaps not filled in the current rehab landscape in Singapore and even in the internationally?
Thanks, YJ, for the question. I think following on from the previous question, I have sort of listed it as not so IT constraints, but more implementation constraints. And I've just put excess here because Alexis reminded me of a point I want to elaborate on wearing the SNSA hat. So I guess first as a practitioner, and Prof. Nielsen did talk about change management. You know, I think in your fireside chat, he said 80% of this is technology transition into the community, it's about change management. And looking at models, both in Victoria, Melbourne, as well as in NHS London, I think when we talk about change management, it can be done using a scientific process, using implementation research. And in Victoria, Melbourne, they have positions now known as Allied Health Research Translation Leads. And these are clinicians with research training, whether it's in implementation science or similar, who act as the people who translate evidence into practice. We know that there's a 17 years gap, and certainly the clinical efficacy in the latest stroke guidelines, there is low to moderate effect size for using virtual reality, low for virtual reality, but moderate for electromechanical gait-assisted training. So as the evidence is building up, we now need to look at the implementation science behind this and using scientific processes and models such as the TDF to look at each site specifically. So what we do know is that the cut and paste model doesn't work. So each site needs to have their own barriers looked at and site-specific solutions to translate the technology into practice. So I think we do need to focus on implementation science as we move forward. Whether we use the Victoria Melbourne model or in NHS, specific companies themselves employ clinician specialists. So when I worked in the UK clinically, Sabo recruited their own clinician specialist, who we then would refer appropriate patients to the clinical specialist. Each model has its pros and cons, and we need to find something that suits our own system. But definitely it's about time that we looked into implementation science in technology-enabled rehabilitation. Wearing the SNSA hat, and sometimes I'm often conflicted. As a therapist, we talk about empowerment and self-management, and that is about discharging them from healthcare and teaching them the resources to manage their own condition at home. To the patient, and definitely to our members, what self-management means is having the autonomy to choose when they want the treatment. And they struggle with the whole notion of you have plateaued, you have reached your rehab potential. To them, definitely our members say, we decide that. I decide when I've reached my potential. And they would ask for evidence that they have indeed reached their rehab potential. So they want access and autonomy to that access. If I decide now, as living with stroke for the last 7 years, that I would like technology-enabled rehab, whether it is to do specifically about improving my walking ability, in which case I may have to go back to the hospital systems to work with a therapist in conjunction with traditional physio. But it could just be about being physically active. And for people with disabilities, being physically active is not just about behavior change. It is about working on gait and balance and having appropriate technology to enable them to do that safely in a community setting, and this is talking beyond ILTC. Our members, our stroke survivors, they want to go to a gym and have these technologies in place there and be empowered to use it themselves whichever time they choose it to be. So I think the healthcare always will have its constraints, and we will always have to have endpoints to which we can deliver therapy. But if technology people like Zen work beyond the healthcare system and provide technologies that are perhaps of a different tier that would encourage independent use, then that is really what our members want. Yeah, thank you.
Thanks, Shamala. So I think we still have a little bit of time. Let me see whether audience have asked questions. Okay, I have a few questions here. Okay. Let me go through. Okay. Oh, there's one question for Zen. Do you see any significant differences in the adoption of assistive tech? Okay, hold on. Okay. Why you gone off again? Sorry. Let me see. Okay, yeah. Adoption of assistive tech across different countries and markets. Is there anyone Singapore should follow, and why?
Again?
Okay, again I repeat. Significant differences in adoption of assistive tech across different countries and markets. Is there any country that Singapore can follow?
Well, this is a very challenging question. Actually, since I got out from NUS to do this thing, right, we tried different models. Frankly, different countries, regions have their own, uniqueness. I think Singapore carved out our own path. For Singapore, I don't think we need to follow any particular model. We need to study different models and cherry pick the best model and maybe like a fusion of different models. For assistive technology and rehab technologies, when we first introduced it in Europe, the clinicians wants it, top of the end, all the features, because they are well trained, they are prepared to be trained, they are prepared to invest time to operate the machines and the assistive tech. Because they think that, I'm the therapist, I know what to do. I'm like, God, no, I know how to do it. But you come to Asia, you give them things, you say, what, are you kidding me? I need to be trained for 2 days before I know how to use it? They don't have the time for that, right? We try to do that in China, they freak out. They say, no, can I have something that just put the patient there, press the button, patient come out walking? I say, that's called washing machine. I haven't built that yet. So, huge disparity. So, and then, of course, the Europeans don't mind paying a bit more because, Akong's money, right? They pay for it. They want the best. Then, when it really very open-ended, they can actually do a lot of things to it because they think that therapists need that kind of really complex device so that they can actually, exploit the potential of the patients. But a lot of the different countries, they prefer much simpler devices. So if I can understand and answer the questions right, I think there are different needs, but nevertheless we're humans, right? So our so-called rehab needs and assistive needs pretty much are the same. So Fourier actually work with different partners through our open platform system because, like I said, we cannot know all. And it would be too costly for a company to try to build everything to suit everybody's needs. Then you don't have economy of scale. So in different regions, we work with different partners so that we can tap on their expertise. We sign meaningful MOUs so that we can work with different clinical groups, research groups, university groups to develop technologies for their respective regions. So I hope I answered your question, but I don't think we should blindly emulate anybody. We should be aware of our patients' needs, like what Singhui has spent time understanding each individual patient's motivations, and then work out a solution for them. I think that is the key, because just have technology, but we don't know how to use it, then it's a white elephant. Yeah.
Thanks, Zen. Okay, we have time for one question. So, Dr. Chua, do you think we need to tweak our current practices, clinical practices. Maybe there are another 4 clinicians here anyway. Yeah, so to actually integrate technology into what we are doing here in the inpatient, outpatient, or community setting. Yeah.
Yeah, I think this is a very challenging question. So I think that, we always have to start with your so-called problem statement or the goal that you want to go to. And as Zen has said, I think that's very individual. If you look at a microsystem, it's individual to the center that you work in, right? So if, let's say, in our center, we deal with the most complex and severe strokes, so burden and productivity is a big problem. Perhaps where Alexis is concerned, you're dealing with patients who are already fairly recovered. They're looking at probably maintaining or sustaining their level of function to age well, for example. So maybe they don't need a lot of lifting and carrying, but they need a feedback as to whether they're actually doing enough exercise, they're keeping mobile, they're keeping physically active. We forget to talk about cognition because honestly, cognition is also key to motor function and vice versa. So whether patients are adequately engaged cognitively, we talk a lot about motor function, but we sometimes neglect whether patients are continuing to build their neural networks as they age and things like that. So I think that this is difficult, but I also think that we underutilize the data that machines collect. Every time you put a technology somewhere, it automatically collects data. The moment you put in the user ID and you turn it on and the patient starts to move in it, for example, your step counter in your phone, it collects a lot of data. But how often do you actually go into the data and think about what the data is telling you about your patient's behavior or activity? So I do think that here is where we need to get more integration between our technology partners, our scientists and clinicians to really make sense of the data and then actually come up with certain algorithm that can look at either prognostication or maybe even prediction. I hope I've scratched a bit on the surface of that.
Any other comments from the other 3 clinicians over here? Yeah.
I do have a comment just on the back of Dr. Chua. In terms of developing technology as well, Zen, I think I will have to pass on the message from our young stroke survivors group that they would like more technology to be focused that is age appropriate for younger people with disabilities and also for smaller pockets of disabilities such as visual impairments after stroke or aphasia. So to incorporate those features as options as you develop your technology. Thank you.
Thanks so much, everyone. A lot of insights. So I'd like to summarize into a various P's. First is looking at people, and people means providers and also patients. I do feel that providers need to be ready to embrace technology. We need to have the skill set. And the patients also need to have awareness and understanding, and also a co-ownership of the technologies that we are going to implement in the hospitals and in the community. The next P is programs. I think we do need to have different suites of rehabilitation programs that embrace technology as an enabler. So basically, we need to define the programs for our patients that to actually guide them through their recovery journey. The next P is actually products. That is where we need to work with industry partners to see how can we come up with products with an end in mind. That means to cater to what the patient's needs, like what Shamala has mentioned, age-appropriate, things like those with visual impairment, even hearing impairment and cognitive impairment. That is something very important. Then next one will be, in a way, partnerships. We need to build a partnerships. That is why this is, in a way, a partnership that is going on here between SNSA, S3, Tan Tock Seng, Fourier. So basically, we need to build partnerships from hospital to community to actually transit the patient's journey. Because with all these 3 Ps, right, we can, 4 Ps, then we can move towards a paradigm shift of bringing rehab technology from hospital to community to last 2 more Ps and result in what we call personalized and also person-centric care for our patients that require rehabilitation in stroke or other conditions. Thanks so much, panelists.
Well, thank you very much to Yongju and our expert panel of speakers. It's certainly been a very insightful session for all of us, and I'm sure for the audience as well. And so with this, I'd like to thank everyone as we have come to the end of the first part of our 4-part series of CHI Innovate 2022.
And thanks to the audience also for your fantastic questions. I know, Youngju, we've got a lot more on that iPad there. So I think Youngju's going to be sending them to the panelists as homework. I'm sorry about that. And we hope that you'll see the answers to those questions in the post-event publicity that we're going to send out after the show. So before you go, for our online audience, we need to find out how you felt about today's event. Please rate our session. Go to the audience power button that you see on your mobile screen or on your laptop screen and look for the poll tab, of course. And for our live audience here, please just scan the QR code that you see on the screen down here. And as Choing said, that brings us to the end of episode 1 of our 4-episode CHI Innovate series for 2022. We've got 3 more to go in the middle of the year, September, and then to our grand finale in November. All right, so see you then.